Good afternoon, everyone. It's a great day. Oh my goodness. It's so wonderful to see so many of you here with us today. So welcome to our Nursing Leadership Lecture Series. As many of you know, I'm Dr. Janie Heath, Dean of the College of Nursing, and I thank you for being here today. It is so rewarding to see so many of our students and faculty who have come from their classes or clinicals or D&P immersion sessions, as well as our university and UK healthcare colleagues, our alumni and faculty emeriti, and also our special community partners and nurse leaders who are here. I'm afraid I will miss someone to name them all, but it looks like they're all right here in the front row. This is the VIP section right up here. So we have executive nurse leadership from Baptist Health, from St. Joseph, from Berea College, Kentucky Nurses Association, current chief nurses of UK Healthcare, and former chief nurses of UK Healthcare. So today you will be hearing from Dr. Diana Mason, a senior policy service professor for the Center for Health and Media Engagement at George Washington University School of Nursing. Dr. Mason is this year's Antonides Williams Distinguished Lecturer, a prestigious designation as a result of the continuous generosity of Dr. Carolyn Williams, Dean Emeriti of the College of Nursing, who endowed this lectureship to help cultivate and prepare the next generation of nurse leaders. Dr. Williams, would you please stand so we can give you a round of applause of appreciation of all of your contributions. Although I would like to say we were able to get Dr. Mason here because of Keeneland, or our bourbon trails, or our basketball team, but it was probably because of her colleague and mentee, Lauren Harden, an American Academy of Nursing Edge Runner and Senior Advisor for the Center for Complex Health and Social Needs, who lives in Eastern Kentucky and is with her today so we can recruit her to our PhD nursing program, okay? So you all are in for a real treat today to hear from literally a world-renowned leader and shaker. And for those of us who know Dr. Mason or are long-standing followers, know she is a mover and shaker at the tsunami level for shaping global, regional, and national policies to improve the health of populations. Dr. Mason earned her BSN from West Virginia University. Aren't you happy about that, Professor Kelso? Yes. MSN from St. Louis University and PhD from New York University, and holds an honorary doctorate of science from West Virginia University and an honorary doctorate of humane letters from Long Island University. She is past president of the American Academy of Nursing, former editor-in-chief of the American Journal of Nursing, and producer and moderator of a community radio program on health and health policy since 1985. She is a member of several boards, committees, and organizations, including the National Academies of Science, Engineering, and Medicine Committee on integrating social needs care into the delivery of health care to improve the nation's health and the public health solutions, which is New York City's largest public health organization that focuses on improving the health of vulnerable families. For our D&P and PhD students in particular, listen up. Dr. Mason is the author and editor of Policy and Politics in Nursing and Healthcare, which is soon to be in its 8th edition. And, I kid you not, it is a book I literally slept with during my dissertation work. She is a prolific writer and well known for her blogs on policy for Health Centera and JAMA News Forum. She is the principal investigator for replication of the 1998 landmark Woodhull study on nurses and the media, which has fascinating results that were just published in the Journal of Nursing Scholarship last year. Please welcome Dr. Diana Mason.
Well, good afternoon, everyone. Post-lunch dip is set in already. Good afternoon.
Good afternoon.
That's the Kentuckians I came to expect. I'm really honored to be here and have had a delightful several days with my colleague Lauren Harden. She is one of the leading people doing complex care work in this country, helping health systems around the country to address the needs of people with complex health needs. And it's amazing work, and I'm always thrilled to be in her presence, and got to spend 2 days with her before today, including out at Maysville, her farm that's outside of Maysville. And so I got to experience some of the Kentucky spring and learn a little bit about Kentucky cuisine, which we won't say too much about. But it has been a fabulous several days. And it's a privilege to come here. Janie, your reputation as the Dean of the School of Nursing is fabulous. You've done a fabulous job. And one of my heroes is Carolyn Williams. I was sharing with her that an article that she wrote posted in 1970s probably, totally informed how I think about nursing and health and what I need to be doing. And it was called Community as Client. And it was about that your patient is not just an individual. There is a community there that is your client. And I was sharing with her that I have a graduate student who was working with me on a community coalition that I'm facilitating on addiction prevention and treatment in upstate New York. And it's SUNY University of New York at Delhi. And I contacted them and said, do you have a graduate student who might want to work with me? And they sent a fabulous student, but early on she said to me, so Diana, tell me how this is nursing. And I said, I want you to go read an article, and it's called Community as Client. She was an oncology nurse, and this was her patient. She was used to the individual patient, and she cared for the family, but she hadn't thought of community as client. And she got it, and she had a fabulous experience. We had her on radio and writing articles and actually speaking at a community action summit that was quite remarkable. So thank you for that groundbreaking work. You did much more than that, I know, and I very much value your work. And it's a pleasure to see these other leaders in nursing and healthcare here. I'm quite honored to have you in this audience and hope that I'll be able to have more discussion with you. You're living the work every day in a way that I'm not. So thank you for what you do. So I have probably way too much material. What I'd like to do today is to talk about the mandate that we have for promoting health in this country and transforming healthcare. And I want to say that those are not synonymous. They are different. And we need to bring them together. One way is by building primary care capacity. I want to speak to that. And then I want to speak to also the social determinants of health and how we need to pay more attention to the impact of social determinants of health on individuals, families, and communities. And I want to share some lessons that we've learned from some nurse-led models of care. I'm getting over a cold that I got in San Diego, Karen Hill. So bear with me. And Lauren Harden is one of the edge runners. And she was in the study. I'm going to share that. She was in the study. I know you wouldn't mind. And I'm going to refer to her work as well. So this is my schematic drawing of what our healthcare system is about, what it looks like. We have as a foundation this incredible acute care system that's costing us over $3 trillion a year, right? We're spending most of our money on that foundation. If you move up the rung, we've got some recovery care that we do provide, some home care that we do provide, but there are struggles there. If you know anybody who's needed home care, they will tell you it got ended way too soon. I wasn't ready. And some people just aren't getting it, is the other issue. Long-term care, I want to know how many of you want to go to a nursing home in your final years? Show your hand. No one. I've had one person, I ask this question frequently, I had one person raise their hand in all the times I've asked it. None of us want to do that. So why do we have nursing homes the way they are? Why aren't we building more community? We know how to do it. It can be done to keep people in their own homes. Primary care is an afterthought, And it became more of a thought with the Affordable Care Act as more people got covered. Then it was like, well, who's going to give them care? We got to build out primary care. And we haven't done it robustly yet. And then we paid very little attention to wellness, health promotion, and public health. The public health sector struggles to keep funding. It's sort of ridiculous. If they do their job well, things don't go wrong. But you don't want them to go wrong. So keep funding public health to do the right thing. So this is what our system is. What's wrong? Whoops, wrong one. What's wrong with that? So there are a number of studies, but I want to talk about this series of work that the Commonwealth Fund has done over the years, a series of studies that looked at 11 peer nations, the United States being one of them, and compared them on their health system performance. And the most recent one was from 2017, but you can see it's over a period of years they replicate this. On this graph, the higher the position, the higher the performance, the lower the position, the lower performance. So at the top we have United Kingdom and Australia. Australia does pretty good, actually. Netherlands, New Zealand, Norway, Switzerland, Sweden. So a lot of European countries, Australia in there. Look at where the US is. We are at the bottom of performing health systems. It's sort of embarrassing when you consider that we spend more than any other country, any of these countries, on healthcare. We are the highest spending and the poorest performance of any of those countries. We are last in access to care, in equity, and healthcare outcomes. We are 10th in administrative efficiency. There is so much administrative waste, it's ridiculous. I can't believe we're still putting up with it. And any of you who have had a family member or yourself has been sick and you've had to go through the insurance gauntlet, it's ridiculous the amount of time that is wasted trying to get care covered. We are 5th in care processes. So I bet if I ask this second row, how much are you talking about care coordination, prevention, safety, patient engagement? It's right up there, right? We're 5th in care processes, despite the lip service we're giving to it. We're 5th. We have poor access to primary care, poorer than these other nations, and we don't have the coverage the other nations have. And one of their conclusions was that your level of income defines the health care you receive far more in the United States than in other wealthy nations. We are a nation of income disparity and health disparities. So, stop and think, where and how is health created? Get a mental picture. Where and how is health created, right? What comes to mind? Well, for many of you sitting in the room, this is what you're going to think of, right? The latest in high-tech, very expensive equipment and designer buildings. These are our health, aren't our hospitals our designer buildings? Now, we may not staff them well, but you will die in a designer building. Sorry, guys, never, I had to say that. So we're really putting a lot of money into the building, and yet we know, although this is controversial too, that medical errors and adverse events are estimated to be the 3rd leading cause of death in this country. In reality, I really don't want to step foot into your hospital. I do everything I can to avoid it. If I do have to step into your hospital, I want to make sure that I'm getting the best care I can get. So I want really good nursing staff. I want it well staffed. I want safety to come first and quality to come first. And I want to be engaged in my care. So we've got a lot of work to do to make this a more highly functioning system, to get beyond the facade of the designer building. So I'm really passionate about, we have to be moving upstream. We have to look at social determinants of health. What are the factors that create health? It's where we live, work, play, and learn. If you're living in an unhealthy environment, the odds of you being healthy are not great. If you're living in a healthier environment, despite yourself, you are more likely to have a higher level of health. These are factors that have a profound influence on health. So this is from a paper in Health Affairs actually in 2014. It was a literature review of what accounts for variation in health, the variance in health? And they looked at these factors and the studies related to these factors. And the reason why you have ranges here is because different studies found different things. But for healthcare is estimated to account for 10 to 25% of the variance in health. But we're spending more than $3 trillion a year on this, or $3 trillion a year on this. Genetics account to up to 30%. And certainly a lot is going on there with genetics, but how much really are we going to be able to do with that at this point? Physical environment was 5 to 10%, and that was before all the havoc that we're seeing wreaked around climate change and the destruction of communities and problems with water, etc. So physical environment actually may be playing a bigger role than was estimated here. Social and economic factors account for 15 to 40% of the variation in health. 15 to 40%. Do you have jobs in the community? Do you have economic development there? Do you have quality education? Do you have adequate housing? Access to food? I heard this morning that there are students at this university who don't have a place to sleep, they go hungry. And it's not just this university. I was in Arkansas, and one of the, it was the Clinton Center, I think. I forget what the name of the program was he was heading. But he said they asked students, what were your concerns? And it had to do with finding a place to live, having housing, having access to food. So these are real, and they're real possibly for people in this room. So these are really important factors that we should be paying attention to. Now, health behaviors account for 30 to 40% of the variation in health. So you can say, well, Diana, so it's up to the individual. It's really on the individual person. So I have some individual responsibility, but if I live in a community where I don't have access to healthy foods that are affordable, and there are food deserts in this country, or if I live in a community where it's not safe, or where there's not adequate housing, what are my choices in having healthy behaviors? So you're telling me to go exercise, and that I should go walk, not in a community that's not safe, not in a community that doesn't have sidewalks and I might get hit by a car. You're telling me to eat differently. What if I can't afford a healthy diet? So healthy behaviors also occur within the context, a social context, if you will. So even healthy behaviors have a social component to it. So there is what Elizabeth Bradley has called the paradox of American healthcare. Elizabeth Bradley was at Yale. She's now the president at Vassar College. She was very interested in the mirror work, the Commonwealth Fund, on the differences in countries, and wanted to take a deeper dive on why are there these differences. Here we're spending all of this on healthcare. We don't do very well at all. We're doing poorly, more poorly than any other country. And she decided to look at what is the ratio in each country of spending on social services to spending on healthcare services. Now, in the United States, we spend 90 cents on social services for every dollar we spend on healthcare. Look at what other countries spend that were in that study. Twice as much on social services as they do on healthcare. $2 for every $1 of healthcare. And they have better outcomes. In fact, she looked at one of the Scandinavian countries where they actually were doing more poorly on some of the indicators of quality of care, healthcare, and yet their health outcomes were better, and it was because of their social spending. Now, and they have better outcomes. In the United States, we define social services as services for the poor, right? Social services in these other countries are for everyone. Everyone gets the maternity leave, paid maternity leave. Everyone gets the respite care when they're caring for their older person. Everyone has the social insurance. So we have to, I think, change how we're thinking about social services And there is this movement to owning up to the fact that social determinants of health, if we don't address them, we can't afford the health care we have. So these are the forces that are in play to try to shift this picture. Healthcare accounts for 17% of our GDP. And that means that's money that cannot go to spend on creating new jobs and to education and to housing, et cetera. And so if we took a little bit of that money from the healthcare system and put it over to building healthy communities, we might be better off. This is a slide, thank you to Lauren Harden, that she used in a recent TED Talk that she did that was fabulous, showing that 5% of the population accounts for 50% of the cost of healthcare. And her work is really focused on how do you change this picture? How do you take that 5% and really develop an approach that's going to decrease the use of healthcare resources, as well as improve their lives, quite frankly. Another force is everybody's talking about moving upstream. The American Medical Association announced this past week or last week, that they were partnering with United Healthcare on looking at how to integrate social determinants of health data into electronic health records and into data collection about patients. So when the AMA is on board, you know, something's moving. The National Academy of Science and Engineering and Medicine has been doing several reports around social determinants of health. And as Janie said, I'm on a committee, I'm the token nurse on the committee for integrating social needs care into healthcare delivery. I was a little bit concerned that I was a token nurse. Most of the people didn't think nurses had really much of anything to do with this. And that is something we need to listen to when people don't see us in this space. What's happening that they don't see us? That report, I can't speak about what it's going to say, but it will come out in August and September, and I hope particularly those of you who are leaders in the healthcare space will take a look at it. There's a lot there, and schools. There's a lot there going to be there on workforce, as well as healthcare delivery design. There's also foundations that are all over this work now. They're looking at how do we build healthier communities. And these are local foundations as well as the large national foundations, including the big gorilla, Robert Wood Johnson Foundation, and its Culture of Health initiative. So I think we need to flip this pyramid. We should have a foundation of health promotion, of wellness and public health. Build the healthy communities. Help people to lead healthier lives. So I also want to give one other example of this whole idea of health promotion and how to invest in this. So when I talked about healthy behaviors, I've had a weight issue my whole life. And when I turned 60, I thought, you know, I need to do something here because I'm in my last transition and my weight is just keep going up. And I hired myself a nutritional coach and lost 40 pounds over 2 years. I've gained a little bit back, but we're working on that. My insurance company would have paid for me to have bariatric surgery, which I never would have done. They would not pay for the nutritional coach. So if we're going to invest in health promotion and wellness, we have to think about what do people need and want to live healthier lives. And it's not bariatric surgery most of the times, God forbid. We need a really robust primary care system with good care coordination for everyone. We need a strong recovery care, home care system, including, I think, home-based long-term care and community-based long-term care. I'm not going to your nursing home. And then for acute care, there are some people who are estimating that acute care in the future, the hospital of the future, is going to be one intensive care unit, pretty much. Yeah? So, how do we flip this pyramid? Well, where is nursing in doing this work? How do we make this change? Well, if we look historically, Florence was all about environment. She was about nutrition. She was about sanitation big time. She got it. Of course, there wasn't much else available then. Lillian Wald, one of my heroes, really got it. It is about where people work and play and live. She created the Henry Street Settlement House on the Lower East Side of Manhattan. She started home care nursing, occupational health nursing, school health nursing. She started the first playground in New York City in recognition that the children were playing in streets where the horses and buggies were barreling down the streets, where there were dead horses in the street, and this was their playground. And it was not safe, and it was not healthy. And she started a playground at the Henry Street Settlement House. She started the first theater at the Henry Street Settlement House in recognition that the arts feed our soul, that part of our health is how we feel about ourselves and our community and our family. And so she started a playhouse. Now that's really thinking upstream and what creates healthy communities and vibrant communities. So we have these, and there are many more examples as well. The Hill-Burton Act came in, though, and I blame the Hill-Burton Act a lot. The Hill-Burton Act came in 1946 after World War II. There is always, during war, advances in medicine that are made, and there was recognition that, gee, we've made such advances, we could share this throughout the country if we had more robust hospital systems. So the Hill-Burton Act gave money to build hospitals, to expand hospitals, in return for those hospitals providing some free care. We were really good soldiers. And who was staffing those hospitals? We stepped up and we staffed the hospitals, and we still do today. But we've become this acute care profession almost, right? And if you look at RNs, how many RNs do you know who are in primary care? If you look at APRNs that I'm talking to are talking about moving into the hospital to do acute care. That's not what we need. I know. They're really good there. I know. And if I'm in the hospital, I'd love to have one. But I feel passionately about the need in primary care is so great that we need to make sure that we're emphasizing that part of what we're doing. And I just want to share with you in terms of nursing education, I have real biases here because I've spent a good bit of time in nursing education. This is a paper by Danuta Wojner and Ella Marie Whalen. Ella Marie's at the Centers for Medicare and Medicaid. And it was published in Nursing Outlook 2017. They surveyed schools of nursing about preparing our baccalaureate students for primary care. And what they found was really appalling. Very few schools really prepare them for primary care. But what was worse is the faculty believe that that's not where we should be teaching primary care. Primary care should be taught at the graduate level. And acute care is at the undergraduate level. Well, where did we ever get that? How did we get there? So I'm not going to ask this room, but I'll have you think back. Anybody here who thought, I really don't want to go do that first job in the hospital? But what were you told? You have to do the year of med-surg, right? And that's enough to kill your spirit for some people. Sorry. So nursing education has a huge role in this in terms of showing the possibilities and partnering with primary care practices around building a more robust primary care system. So I want to focus on that for just a minute. How do we build a more robust primary care system? We have to focus on health promotion and wellness. We have to look at integrating a focus on social determinants of health. We should know what are the issues that are influencing the health of the patients we have. And it's not just in primary care, you should know this in acute care as well. We have to improve chronic care management, care coordination, health education, and coaching. And we've got to integrate behavioral health. We're not doing very well here still. So this is a report that came out, the American Academy of Nursing partnered with the Josiah Macy Foundation. It was an invitational conference on using registered nurses as clinical leaders in primary care, really. How to transform primary care using RNs. And that's where the Danuta Wojner paper, it was a commissioned paper for this report, and they brought that data back to our deliberations. And it was really quite informing. A member of our committee was, for this report, was Tom Zinski, who's an internist in Iowa, although I heard he just stepped down. He and his wife, Christine Zinski, were concerned about how disturbed they were about their practice. They just weren't having any joy in practice. And so they did a survey of what some of their physician colleagues were doing that was giving them joy in primary care practices. And they found that those practices that really used RNs well were doing better. The physicians were feeling joy in practice. And so they changed. They had an RN who worked in their practice. They changed, and he had 2 or 3 RNs who were working just with him. And he said, the nurse was really the care team leader. When you came in, the nurse is the one who did your initial assessment and was responsible for making sure your wellness care and preventive care was up to date. They would interview you, they would take you into this room and do some semblance of a physical assessment. And he said, and then I would walk in the room and the nurse would report out to me with the patient there, and it was this 3-way conversation. And I would say, let's try this, or what do you think about doing this? And then we'd agree on what the plan was, and the nurse would then follow up. He said, so I was practicing at the top of my license. That nurse was practicing at the top of her license. The patients were getting better care. I had joy in my practice, the nurse had joy in her practice, and the patient felt better about the care they were getting. We could transform primary care if we prepared RNs to work in that space, and if schools of nursing would partner with primary care practices to help them redesign their primary care. Because these practices think, I can't afford to have an RN. And he would tell you he saw a higher volume of patients because he wasn't with them as long, but the time he was with them was meaningful, and these patients were happier in the end. So this report is recommending that we've got to change our healthcare culture. First of all, the leaders have to speak up and say primary care has to be a focus. We have to change the practice environment. There are laws that get in the way of doing some of this, of reimbursing nurses for what they're doing, et cetera. We have to educate nursing students in primary care. We have to look at how do we take the RN who's, been on that med-surg unit for years, is very experienced, but is getting worn out with the physicality of that work. That nurse could be superb in primary care. Would need a little bit of retooling, not much, but could be an outstanding clinician in that primary care space. Developing primary care expertise in the nursing school faculty, one of the things we discovered, that most schools of nursing don't have the expertise on faculty. They have it at the advanced practice level, but not necessarily at the RN level. So in California, at the summit, there was a nurse who was a faculty member who was placed in a primary care practice for ramping up those skills, and then she was taking students as well. And obviously, we have to increase the opportunity for interprofessional education. So I would challenge you to think, where is primary care in your communities, and what could be done to transform that primary care to be more robust, be more effective in promoting health, keeping people out of hospitals. But how do we move upstream? And the Robert Wood Johnson Foundation has a culture of health model that I'm going to mention. Each of these action areas has 4 action areas: making health a shared value, fostering cross-sector collaboration to improve health, and Lauren Harden is doing a lot of work on this cross-sector collaboration, bringing everybody to the table. 3, creating healthier, more equitable communities. 4, strengthening the integration of health services and systems. So really a lot of work in this space. Around this is equity, that the aim here is equity. Now I want to just share this slide that I found very helpful to differentiate between equality and equity. It's not about health equality. We are different people. If you approach it as equality, we want everybody to have the same thing. You're giving everybody the same size bicycle. Doesn't matter that this person's in a wheelchair and can't use it. Doesn't matter that this person is really too tall for that bicycle, and it doesn't matter that this person's too short. They're all getting the same thing. That's not really what we want. We want equity, where you're giving people what they need to be healthy and successful. It's the bicycle that works for them, okay? I thought it was a great representation. It's come under some critique too, though. We won't go there today. So I want to share with you what some of these edge runners are doing, and this is Lauren Harden is one of these edge runners. The American Academy of Nursing has this edge runner program. It's for nurses who have designed innovative models of care for which there are good clinical and financial outcome data, and they have had to sustain them and spread the models. You can see all of them on the Academy's website. As I was going out of my presidency at the Academy, we got a grant from the Robert Wood Johnson Foundation to partner with the RAND Corporation around looking at what are these models doing in the space of building a culture of health. So the lead on most of this work is Grant Martzoff. He was with the RAND Corporation, still has an affiliation with them, but moved over afterwards to the University of Pittsburgh School of Nursing. Great guy. So I want to share with you what we found. We used the culture of health model, and the first area is making health a shared value. So helping a community to view health as a priority, engaging a community, improving population health. And what we found in our study was that for the edge runners, this meant that patient and family focus is necessary to get to the community level. The culture of health model goes right to the community level. And we've had conversations with them about, but if you don't bring along the individuals and families and address that level, you're not going to get to the community level. And so these edge runners showed us that that becomes a really important component. You can't just focus community level, you must pay attention to individual and family. Also, that nurses know how to meet people where they're at. And this actually, I thought about this at one of our discussions this morning, emphasizing the value of both culturally accurate and medically accurate information. We cannot divorce the evidence from the cultural evidence, the scientific evidence and the cultural evidence. We have to blend those and find a way to bring that kind of evidence together when we're designing care in partnership with people. So here's an example, and it's centering healthcare. This is Sharon Rising, who started, do you have centering pregnancy here? Mm-hmm. This is who started it. She's a nurse midwife, and she does group approaches to prenatal care. As a midwife, she got tired of saying the same thing to everybody all day and thought, why am I doing this? Let's bring them all together. And so she actually creates a community with them, and her role is as facilitator. She's got randomized clinical trials. So the women come in, they do their own weights, they take some responsibility for their health in that way, the weights, the urine tests, whatever they do. And then they have a group discussion, and there might be a certain topic, but she gave us an example that's quitting smoking is one of the things that you want the women to do. And it was a topic at one of the groups. And these women, a couple women said, oh yes, I've quit smoking. And then this one woman said, oh, I'm gonna quit after my baby's born. And the women in the group jumped all over her and said, how stupid is that? That is stupid. And Sharon said, I could never sit in a group and say, how stupid is that? She said they used the peer pressure, and that woman quit smoking before her child was born. So it is the community, the peer support, the empowerment. And many of these parents would stay connected afterwards. She's got randomized clinical trials with really great outcomes. She's moved on to parenting centering parenting, centering congestive heart failure, centering diabetes. And she has a whole institute on centering healthcare. The issue is who's paying for group care, which is a whole other issue. Nurse-family partnership, I assume you have it here. I'm not going to really talk about it, but this is another example of making health a shared value, with nurses working with individuals and with families to create a shared vision for health. Action area 2, fostering cross-sector collaboration. And this is with businesses, with education, with the social services sector, with schools. And in the RAND study, what we found was that successful collaborations, and Lauren Harden's going to know a whole lot more about this than I'm going to share with you, you have to be embedded in the community and in the institutions of power. You can't just sit in the university and be effective in a community. You have to be with community, be in community. But you need to know how to work that system of power. So they talk about you have to have a shared vision and language with all partners. So what is that shared vision that we have? Lead with strength and tenacity. And then Lauren in her TED Talk said, being heard, what matters most. And that's where you have to talk about what matters most to you. And that's with individual patients you have, what matters most to you, as well as with communities, what matters most to this community. These are two other edge runners who are doing work with children, with parents, how to be better do better parenting, as well as how to have teachers be more effective with managing children with behavioral problems in schools. This is Debbie Gross with the Chicago Parenting Program and Sandy McClowry with Insights. Actually, I think Sandy has something going on in Harlan, Kentucky. I could be wrong on that, but I think somewhere in Kentucky, somewhere in Appalachia. The third action area is strengthening healthcare delivery systems. This woman is not an edge runner, but it's, I think, a beautiful example of how you can do this just by having a vision for it. This is Connie Hill Williams. At the time, she was Connie Hill at Children's Hospital in Chicago. I was at the American Journal of Nursing and went on a site visit there. Her unit was a respiratory unit. She had kids on respirators. And she said, I said, what's your passion up here? She said, these kids are on these respirators. They're here too long. They don't need to be here. They need to go home. They want to go home. Their parents want them to go home. But they're not the supports in the community to keep them at home. They don't need a whole lot. They need a little bit. So she formed a coalition with the school system, Medicaid providers, social services, the equipment providers, and she was able to reduce the length of stay for patients on her unit, for the children on her unit. And she said, it's really about what do patients and families and communities need and want. It's not what we think they need and want. What do they need and want? And we need to address that. Action area 4, the last one, creating healthier, more equitable communities. We have nurse-managed health centers. You have a nurse-managed health center? Quasi, okay. So there are about 250 across the country, but I want to highlight just one. This is Donna Teresi, who heads up the Family Practice and Counseling Network, which is the umbrella organization in Philadelphia for the Stephen and Sandra Scheller 11th Street Family Health Service. This health service, the 11th Street Family Health Service, was started by Patty Garrity, a public health nurse, in a very poor, mostly African American community section of Philadelphia, North Philadelphia. And she has now retired, and the current director is Roberta Waite, and she's bringing additional vision to this work. Patty Garrity went to the community and said, I want a room in your housing project to put a nurse in. She was affiliated with Drexel University and was on faculty there. And the community said to her, you know what? We're tired of you university people coming in our community, doing your thing, and then leaving us. And she said, I'm not going to leave you. I'm going to stay with you. Yeah, right. As a good public health nurse, she knew she had to prove herself. And so she said, what's important to you? And they said, you see this road out here? We need a stop sign out there because cars go barreling down here. They hit our elders who are trying to cross the street. They hit our kids who run out to get the ball. We need a stop sign. And Patty knew she had to deliver a stop sign, and she did. And when she delivered that stop sign, they said, now we can talk. And she formed a community advisory board that indeed has stayed with, they still have one, that's involved in all policy setting at this health center. They have totally embraced the center. She went from a room in a housing project to a gorgeous, endowed Stephen and Sandra Scheller federally qualified health center that is one of the few sanctuary certified health centers in the country because of the trauma that goes on. There's a lot of violence in the community, a lot of trauma. They got trauma certified. They got sanctuary certified so that this is a space where we're not going to traumatize you more, and they know how to live up to that. Major health problems, obesity, diabetes, congestive heart failure. So they figured we better do something with nutrition. They started nutrition classes. Nobody came. They're boring, right? She started cooking classes, and they have a waiting list of people who want in the cooking classes. And what do they do in the cooking classes? They teach nutrition, right? They have a gym. Anybody from the community can come and use the gym. They created a community garden. They brought in farmers from outside the city to come and bring their produce for farmers markets. It is just such a brilliantly inspired example of how to integrate what matters to communities and what they need and social determinants of health into healthcare delivery. They have great outcomes. I really always look to what are they doing next. Their primary care teams are led by nurse practitioners. They have physicians from Drexel who will come over and do specialty services. They have the medical legal services on site. They have behavioral therapists. It's really an outstanding place. So we wanted to look at, I'm not going to say much about this, what are the commonalities across all of these edge runner models? It was published in Nursing Outlook back in 2015. What we found across these nurse-led models of care was that health was defined holistically, which is why I was so surprised to be on this social needs care committee and have people not understand that nurses are in this space, that we are educated this way about social needs. That's part of how we define health. Nobody else knows this. They think we're all acute care. That we are individually, family, and community-centric. People understand, I think we do understand, we are educated that a person lives in a community. What we do with that is another issue. That relationships are key to that centricity and to patient, family, community engagement. But those take time. And as nurses, we say we have to spend that time with patients to build that relationship, and that's important. That group and public health approaches matter. So Sharon Rising's model is a group and public health approach. So we have these commonalities that our health system needs. We get it. And so some of the takeaways from all this work are, one, that these nurse-designed models of care really can inform what the health sector does around building a culture of health. We need strong leadership, broad community support. That's key to success. We've got to be leaders in this space. And others are in this space. We will be lost if we don't step up very quickly to get into this space. We are well positioned to lead and should be included in culture of health initiatives. And nurses who design and lead innovative models of care really are visionary, creative, persistent leaders. Nurses don't give up easily. And we are creative. We know that when you're short on something, you'll find a way to make it work, right? If you don't have enough sheets, you figure out another way to do it. And nurses are leaders in developing health-promoting public policies, or ought to be. We need that leadership. And how do we create healthier public policies? We have a vision and an understanding of health we have to put to work. So I'm running out of time, but I want to leave you with a question is, do we as nurses have a social and professional mandate to move upstream? In practice, I absolutely think we do. In our research, what kind of research are you doing? And are we doing the research that matters in this space? And education, are we educating people to do this kind of work? And are we at all decision-making tables related to healthcare? You've got a Kentucky Nurses Coalition, I don't think I've said the right name, but the Action Coalition, that I'm sure is working on nurse appointments, as most of the coalitions are across the country, right? And so we need to not just be on hospital boards, we need to be on boards related to farming and access to healthy foods, transportation, environment, economic development, school boards. You name it, we should be at those tables, particularly when we talk about social determinants of health. Are we using our voices and stories to shape public policies? We are not using our voices as strongly as we need to. I don't have time to go into the Woodhull study, but probably more important than the Journal of Nursing scholarship paper, we published interviews that we did of health journalists about their experiences with interviewing nurses for their stories. And this they tell us in the American Journal of Nursing from October, in that article we talk about what are the barriers to them using nurses as sources. We are part of the problem. We're not the whole problem, but we're part of the problem. So we are cited in Health News Stories in leading print publications 2% of Health News Stories. In 1997, it was 4%. Now, the difference isn't statistically significant, so we don't say things have gotten worse, but. So finally, just the public needs us to be visible leaders. And we need to speak up and be the leaders that I think the public needs. We need to transform healthcare in this country. It's not working. And as hard as you guys are working, God love you. I know you're trying to move this ship, and it's a really hard ship to move. I think we have to move in the direction of how do we reduce what that ship is doing and build healthier communities. And I think all of us have a role to play, including in our own communities as volunteers. So I'd like to stop and have you, we've got just a few minutes, I'm sorry I didn't stop earlier, and just see if there are any pushback or any questions. I'd welcome them. Don't be shy.
What kind of pushback did you get on the inequity and inequality? I couldn't figure out why you were being pushed back on that. You said there's pushback on that?
Just on that model. The model, there's another schematic that's about, no, you don't, you remove the barriers. And I almost brought the other, it's very complex, but it's about, there's another visual of having people watching a baseball game, and you give everybody the same stool, right, to look over the fence. Well, if you're too short, you're not going to look over it anyway. So you give them the size step that they want. The real work is getting rid of the fence. If you can give anybody the stools of the same size, but something else is going to be an issue, we've got to get rid of the fence. It's the structural, changing the structural underpinnings of our society. Yeah. Somewhere back here? Yeah.
Say who you are, your program is setting. Okay, I'm Jen Yankee, and I'm in the Doctor of Nursing Practice program to be a family nurse practitioner. And I love this social stuff. Are there nurses who are doing studies in churches? Because my thought is that the church has a community. Oh, okay.
Okay, go up. Tell her. Tell her. Go. Stand up.
I'm not from Orleans College of Nursing. I'm from Mississippi. It's a built-in community, and with a community, you get social pressure, and it all works together.
Yeah, great, great. And there was an edge runner who was with parish nursing early on. I don't think she's still up there. Karen, yeah.
I've seen a lot of work, and of course we've substantiated that nurse residency programs are good for transition. I brought up last week at ALNE that I've seen few models except some from MD Anderson, specifically for oncology. Nurse practitioners going into primary care, regardless of their experience, need transition programs, and I'd like to see some models published in the future because they end up getting sucked up into the medical model because there's not a nursing transition program to help them.
Yeah.
So I think it's a big need.
Yeah, so the transition programs for nurse practitioners, you're absolutely right. Plus, the nurse practitioners of yesteryear were 25-year nurse experienced nurses. New graduates are not. And quite frankly, we're fighting, right, in some states to get rid of any requirement for supervision. Don't give me somebody who's just come out of school and hasn't had that kind of a residency experience. I'm sorry. I think they should be supervised for a period of time. So I think you're absolutely right on the residencies, and I hadn't even framed it that way, that they're too caught up in the biomedical model and losing the nursing piece. Yeah. Carolyn.
Is Marcia Stanhope here?
Hey.
The reason I ask is Marcia we had sort of, we piloted such a thing some years ago, remember?
Piloted what?
I don't know if you can hear it. We had a situation, a new graduate came out of another school somewhere in the country.
Marcia was running our Good Sam Nursing Center, and there were a number of clinics, and we did have some young nurse practitioners who worked with more senior people in those clinics. And so, you know, it was also in context the other thing that happened, we were in a situation some years ago where anybody who graduated with a BSN almost in this community had to go to the hospital for a job. They could not go into public health. And we felt that that was not necessarily the way it should be.
Good.
And so we created the post-baccalaureate residency effort through our center, for our Good Sam Center, where we had nurse faculty in various settings across the community and some out in more rural settings. And we got funding from the Good Sam Foundation here in Lexington, and ran that. Marcia Stanhope ran that program for how many years? Yeah. Anyway, we have there's some publication about it.
Great.
But and the reality is that then these people, they got their first year of nursing in a community environment.
That's great. Yeah.
But unfortunately, many of them went on to become primary care nurse practitioners, other things. But there are not the jobs at that time in in settings outside of hospitals were very limited for nurses.
Yeah.
But anyway, I think it's a great idea, and I'm glad that people are beginning to talk about it now.
And I know, go ahead.
Comment about the residency piece. Can we take the mic? Yes. I had a comment about the residency piece. I'm past president of National Organization Nurse Practitioner Faculties, and I actually had the opportunity to speak at IOM, and I did testimony about this. And the reason why I did, and this was in 2016, was because at that time, we had a chance to go to a meeting. They wanted to mandate all nurse practitioners that graduated went through a mandatory, and we don't have the data to say that we need a mandatory 52-week barrier to practice, which is what they were going to pass. So I absolutely agree. We need to take hold of this, though, nursing, so medicine doesn't. So I did have the opportunity to do the speech at IOM, and then 3 IOM people that were on the committee asked to meet with me afterwards.
Great.
They reframed that. They've asked nursing to look at the education pieces that we call residencies. Could we really look at that and make that more of a residency where those nurse practitioners are going to practice? So it's up to us, though. If we don't take hold of that, they will.
Yep.
So there's no data to show that we need that. Right now, it's a barrier to practice. And at that time, I could tell you there were 19,763 NP graduates. Our main problem right now is preceptorships. So where do we think we're going to get those? They're not going to fall out of the sky.
Right. And I will say organized medicine is using this as a talking point against removing supervision and collaboration from barriers from state laws and regulations. So I'm over time, but I want to just end by saying you're in a state that is challenged to improve the health of its people, to say the least. Yes. And you each have a role in stepping up and saying, we have a vision for how to do this, and we are ready to step up to that vision. So I would challenge each of you, I don't care what your position is, to think about how would we best promote the health of the people in our communities, and follow that vision, make it a passion. You can change the health of this state. So I challenge you for that. Thank you. Thank you. Thank you. All of the public health.